I have a confession to make, and it is one that took me a long time to feel comfortable saying out loud, because it goes against what many of my colleagues still practice, and what millions of seniors are told every single year by their doctors. Here it is. There are 5 intestinal and digestive tests that I, as a physician who has spent decades in medicine, would personally refuse to get after age 60. Not because I do not believe in medical testing, I absolutely do, but because after 60, the risks of certain gut tests change dramatically, and the benefits that make sense for a 45-year-old often do not make sense for a 68-year-old, or a 75-year-old, or an 82-year-old. Last month, a patient of mine, a sharp, healthy 74-year-old retired teacher named Barrett, came to me after her gastroenterologist had scheduled her for 3 separate intestinal procedures in the same year. She looked at me and said, "Do I really need all of these?" And my honest answer changed her healthcare plan completely. Today, I am going to give you the same honest answer I gave Margaret, because you deserve it too. Stay with me. Hello and welcome back to the channel. If you are new here, I am so glad you found us. This channel exists for one reason: to give people over 60 the kind of honest, practical, individualized health information that is too often missing from a standard 15-minute doctor's appointment. Today we are talking about intestinal and digestive health testing, specifically the 5 tests that I believe are being overused, overprescribed, and in many cases actively harmful for seniors over 60. Now, before we dive in, let me be very clear about something important. I am not telling you that digestive health screening is unimportant. It is critically important. Colon cancer, inflammatory bowel conditions, and digestive disorders are real and serious threats to seniors. What I am saying is that not every test is appropriate for every person at every age. And after 60, the calculation changes. The risks of certain procedures go up. The benefits of others go down. And some tests lead to a cascade of follow-up procedures and treatments that do more harm than good. The medical term for this is overdiagnosis and overtreatment, and it is one of the most significant problems in senior healthcare today. So let us go through all 5 of these tests. And for each one, I will tell you exactly what the test is, why it is problematic after 60, what the research says, and what you should consider doing instead, starting with the one that surprises most people the most. Intestinal test number 1. Repeat colonoscopy after a clean screening history. Let us start with colonoscopy, because it is the most commonly recommended intestinal test for seniors, and it is also the one most frequently performed unnecessarily in people over 70 and 75. First, let me be clear about what colonoscopy is good for. For adults aged 45 to 75 who have never been screened, colonoscopy is a powerful tool for detecting colon cancer and precancerous polyps. It genuinely saves lives in this population. But here is where the math starts to change after 60, and especially after 70. Colon cancer takes an average of 10 to 15 years to develop from a small polyp into an invasive, dangerous cancer. If you are 72 years old and your last colonoscopy at age 62 was completely clean, meaning no polyps, no abnormalities, no concerns, your risk of developing dangerous colon cancer in the next 10 years is extremely low. Yet many gastroenterologists will still schedule a repeat colonoscopy at age 72, and again at 82, not necessarily because the evidence supports it, but because it is the standard protocol. And in medicine, protocols are powerful, even when the evidence behind them is weaker than most people realize. Here is the problem with repeat colonoscopies in seniors. The procedure itself carries real risks that increase significantly with age. First, there is the bowel preparation, the strong laxative solution you must drink the night before to empty your colon. In younger adults, this is uncomfortable but manageable. In seniors over 70, especially those with kidney problems, heart conditions, or diabetes, the bowel prep can cause dangerous dehydration, dangerous electrolyte imbalances, particularly drops in potassium and sodium levels. These imbalances can trigger heart rhythm problems, confusion, falls, and hospitalization. I have personally seen seniors end up in the emergency room from colonoscopy preparation complications before they even got to the procedure itself. Then there is the procedure itself. It requires sedation, and sedation in seniors over 70 carries elevated risks. Respiratory depression, confusion after the procedure, sometimes lasting days, falls during recovery, and the risk of aspiration. The procedure itself also carries a small but real risk of perforation, a tear in the intestinal wall that can require emergency surgery. Studies show that the risk of perforation increases with age. A perforation rate that might be 1 in 1,000 in a 50-year-old can be 1 in 300 or higher in an 80-year-old with a less elastic colon. The U.S. Preventive Services Task Force guideline is clear. Routine colonoscopy screening for colon cancer should stop at age 75 for most adults and should not be performed at all after age 85, regardless of health status. For adults between 76 and 85, the recommendation is individualized. It depends on overall health, life expectancy, and prior screening history. Now here is what you can do instead that is far safer. Stool-based testing. Tests like the fecal immunochemical test, known as the FIT test, or the multi-target stool DNA test, known as Cologuard. These tests can detect blood and abnormal DNA in stool that may indicate colon cancer or precancerous changes. They are non-invasive, no preparation required, no sedation, no perforation risk, and for seniors with a clean prior colonoscopy history, they provide a meaningful level of protection without the procedural risks. Talk to your doctor about whether a stool-based test might be the right approach for your specific situation. Intestinal test number 2, upper endoscopy for vague stomach symptoms in seniors. The upper endoscopy, also called an EGD, which in simple terms means a camera passed down through your mouth, through your esophagus, into your stomach and upper small intestine. This procedure is extremely valuable for diagnosing specific conditions: active bleeding in the upper digestive tract, suspected ulcers that are not responding to treatment, difficulty swallowing that suggests structural problems, and suspected esophageal cancer in high-risk individuals. For these specific targeted indications, upper endoscopy can be life-saving. But here is what concerns me. Upper endoscopy is increasingly being ordered for vague, non-specific symptoms in seniors. Things like, I have had some stomach discomfort, I feel a little nauseous sometimes, my appetite is not what it used to be, my stomach feels off. These vague symptoms are extremely common in seniors, and they can have dozens of causes: medication side effects, slower gastric emptying that is a normal part of aging, mild constipation, anxiety, dietary changes. But when a senior presents with these vague symptoms, upper endoscopy is often ordered reflexively, without first trying simpler, safer approaches. And this matters because upper endoscopy in seniors carries real risks, the same sedation risks we discussed with colonoscopy, plus an additional risk of aspiration, breathing stomach contents into the lungs, which is higher in seniors whose swallowing reflexes may be somewhat slower. The American Gastroenterological Association's own guidelines, from the Choosing Wisely campaign, specifically recommend against performing upper endoscopy for uncomplicated gastroesophageal reflux disease or GERD when symptoms have responded to treatment. Yet it is commonly done, and in seniors over 70 with multiple medications and underlying health conditions, the risk-benefit ratio of this reflexive approach is often poor. What should be tried first? A trial of proton pump inhibitors for acid reflux symptoms, H. pylori breath testing for suspected H. pylori infection, which is non-invasive and very effective, dietary modification, medication review, since many medications commonly taken by seniors cause stomach symptoms, and careful clinical evaluation. If these approaches do not resolve the symptoms, then targeted upper endoscopy becomes much more justified. The key principle is this: the least invasive, lowest risk approach that can answer the clinical question should always be tried first, especially in seniors over 60. Intestinal test number 3, capsule endoscopy for non-specific findings. Capsule endoscopy is a fascinating piece of technology. You swallow a small camera capsule about the size of a large vitamin. As it travels through your entire digestive tract over 8 hours or so, it takes thousands of photographs. Those photographs are then reviewed by a gastroenterologist, looking for abnormalities in the small intestine, the part of the digestive system that neither a regular colonoscopy nor an upper endoscopy can fully reach. For specific targeted conditions, capsule endoscopy is genuinely valuable, finding the source of unexplained gastrointestinal bleeding that has not been identified by other tests, evaluating known or suspected Crohn's disease of the small intestine. These are legitimate evidence-based uses. But here is the problem. Capsule endoscopy is increasingly being ordered after incidental findings on other tests or for non-specific symptoms, without a clear clinical reason. A senior has an abdominal CT scan for an unrelated reason. Something vague is noted in the report. The next step becomes capsule endoscopy, or a senior reports vague abdominal discomfort, and after colonoscopy and upper endoscopy find nothing. Capsule endoscopy is ordered to look at the small intestine, even when there is no specific reason to suspect small intestinal disease. Why is this concerning for seniors? First, in seniors with conditions that slow digestive motility, which is extremely common after 70, the capsule can become retained, stuck in a narrowed section of the intestine. This is called capsule retention. And when it happens, it can require either endoscopic or even surgical removal, a serious complication in an older adult. Before any capsule endoscopy, a patency capsule test or imaging should be done to ensure the intestine is wide enough for safe passage. But this step is sometimes skipped. Second, the procedure generates enormous amounts of data, thousands of images to review, and incidental findings. Things that look abnormal but may be completely harmless are extremely common. These incidental findings then drive more testing, more procedures, more anxiety, and a cascade of interventions that may ultimately be completely unnecessary. What should you ask your doctor before agreeing to capsule endoscopy? Ask specifically, what clinical question are we trying to answer with this test? What will we do differently based on the results? Is there a less invasive way to answer this question? Has my intestinal motility been evaluated to ensure the capsule will not get stuck? These 4 questions alone can prevent a great deal of unnecessary testing and potential harm. I want to pause here for just a moment, because if you are over 60 or if you are caring for an elderly parent or loved one, what we are discussing today is genuinely important. The medical system moves fast, tests get ordered, procedures get scheduled, and patients, especially older patients who trust their doctors completely, often say yes without fully understanding the risks. You deserve to understand the risks, and you deserve to ask questions without feeling like you are being difficult. If this video is giving you the tools to do that, please hit the like button and subscribe to our channel. We publish new senior health content every single week. And please share this video with someone you care about over 60. Knowledge is protection. Now let us continue with test number 4. This one affects a surprisingly large number of seniors, and it is one of the least talked about. Intestinal test number 4. CT colonography in seniors with multiple health conditions. CT colonography, also called virtual colonoscopy. This test uses a CT scanner to create detailed 3-dimensional images of the inside of the colon, without needing to pass a camera scope through the intestine. On the surface, it sounds like the perfect solution for seniors who want colon cancer screening without the risks of traditional colonoscopy. Less invasive, no sedation required, faster procedure time, and for certain groups of seniors, it genuinely is a reasonable alternative. But here is what many seniors are not told. CT colonography still requires full bowel preparation, the same strong laxative prep that carries risks of dehydration and electrolyte imbalances in older adults. So the main risk of traditional colonoscopy preparation is still very much present with CT colonography. But there is another concern that is even more significant. CT colonography involves radiation exposure. The amount of radiation from a CT colonography is roughly equivalent to 3 years of natural background radiation. For a 45-year-old, this radiation dose carries minimal lifetime risk. For a 75-year-old with a life expectancy of perhaps 10 to 15 more years, the radiation risk is proportionally much lower because of the long latency period for radiation-induced cancer. But here is the bigger problem. CT colonography finds things outside the colon because the CT scanner images the entire abdomen and pelvis, not just the colon. It frequently identifies incidental findings in other organs, things on the kidneys, things on the liver, small masses on the adrenal glands, lung nodules if the scan extends that high. Studies show that CT colonography identifies clinically significant extracolonic findings in approximately 10% of patients, and incidental minor findings in up to 40%. Think about what this means for a senior patient. You went in for routine colon screening. You leave with a report mentioning a small finding on your left kidney, a slightly enlarged lymph node, and a 6mm lesion on your liver. Now begins a cascade. Follow-up CT scans, MRI imaging, possibly biopsy, months of anxiety, multiple additional procedures, significant medical costs, and in the vast majority of cases, all of these findings turn out to be completely benign and harmless. But the cascade of testing to reach that conclusion carries its own risks and its own emotional toll. The medical term for this is the incidentaloma problem. Incidental findings that get found because of broad imaging that would have been better left undiscovered, because they would never have caused harm. This problem is especially significant in seniors over 70, because incidental findings become more common as bodies age, and the chance that any specific finding represents true disease becomes lower. What is the bottom line? For seniors over 75 with a prior history of normal colon screening, the risks and downstream consequences of CT colonography often outweigh the benefits. A conversation with your doctor about stool-based testing alternatives is always worth having first. Intestinal test number 5. Repeated endoscopic surveillance for Barrett's esophagus in very elderly patients. This final test is one of the most nuanced and least understood, and it affects a significant number of seniors over 65. Barrett's esophagus is a condition where the normal lining of the lower esophagus changes. It becomes a type of tissue more like intestinal lining. This happens as a result of long-term acid reflux damage. Barrett's esophagus does carry a slightly elevated risk of developing into a specific type of esophageal cancer called adenocarcinoma, and because of this cancer risk, standard medical guidelines recommend regular endoscopic surveillance every 3 to 5 years for patients without concerning cell changes, more frequently if abnormal cells are found. This surveillance involves repeat upper endoscopy, with biopsies taken from the affected area. For a 55-year-old with Barrett's esophagus and 25 or 30 years of life expectancy ahead, this surveillance makes clear clinical sense. The cancer risk is real, and the benefit of early detection over decades is meaningful. But for a 78-year-old with Barrett's esophagus, multiple other health conditions, limited mobility, and a realistic life expectancy of perhaps 5 to 8 more years, the calculation changes dramatically. Here is the reality. Even among people with Barrett's esophagus, the actual risk of developing esophageal cancer is relatively low, about 0.3% per year, or roughly 1 in 300 people per year. For a 78-year-old with 5 to 8 years of expected life remaining, the cumulative cancer risk over that period is approximately 1.5 to 2.5%, meaning that out of 100 elderly patients with Barrett's undergoing repeated surveillance, perhaps 1 or 2 will actually develop esophageal cancer detectable by this surveillance. The other 98 or 99 will undergo repeated upper endoscopies, with all associated sedation risks, aspiration risks, recovery time, and anxiety for a cancer that will never develop. The American College of Gastroenterology guidelines now explicitly state that endoscopic surveillance for Barrett's esophagus may be discontinued in patients with limited life expectancy or significant comorbidities, where comorbidities simply means multiple other health conditions. But this guideline is not always followed in practice, because stopping a surveillance protocol feels counterintuitive to both doctors and patients. It feels like giving up, but it is not giving up. It is making a wise, evidence-based, individualized decision that respects both the risks of the procedure and the realities of aging. What should you discuss with your doctor? Ask specifically, given my age, my overall health, and my other medical conditions, does continuing this surveillance actually benefit me? What is my personal estimated risk of developing esophageal cancer in the next 5 to 10 years? What would we do if we found cancer at my age and with my health conditions? That last question is perhaps the most important, because if the honest answer is that treatment of detected cancer would itself be too risky given your overall health, then the surveillance that detects it serves no practical purpose. This is a deeply personal conversation, one that deserves time, honesty, and mutual respect between you and your physician. So what should seniors over 60 do for their digestive health? Here is a practical and evidence-based framework. First, if you have never had colon cancer screening and you are under 75, get screened. But discuss with your doctor whether stool-based testing, like FIT or Cologuard, might be a safer starting point than colonoscopy. Second, if you have had a clean colonoscopy in the past 10 years and you are over 70, ask your doctor whether stool-based annual testing can replace repeat colonoscopy. For most people with a clean prior history, The answer is yes. Third, if you have vague digestive symptoms, nausea, bloating, mild discomfort, ask for a medication review first. Many drugs commonly taken by seniors cause digestive symptoms. Try dietary adjustments and simpler, non-invasive tests before agreeing to endoscopy. Fourth, if a CT scan or other imaging mentions incidental findings, ask your doctor, is this finding likely to affect my health in my expected lifetime? What is the risk of investigating further versus monitoring and watching? Do not let incidental findings automatically drive a cascade of further testing without this conversation. Fifth, for any surveillance protocol you are currently on, ask your doctor annually, does this surveillance still make sense for my age and my current health situation? Guidelines evolve, your health changes. What was right at 65 may not be right at 75 or 80. And sixth, focus on the lifestyle factors that truly protect digestive health. A high-fiber diet rich in vegetables, fruits, beans, and whole grains. Regular physical activity, even gentle walking, significantly reduces colon cancer risk. Maintaining a healthy weight, limiting alcohol, not smoking, staying well hydrated. These unglamorous daily habits prevent far more digestive disease than any surveillance test ever could. Let us quickly recap the 5 intestinal tests that I would personally approach with great caution after age 60. Number 1. Repeat colonoscopy after a clean prior screening in adults over 75. Consider stool-based testing alternatives instead. Number 2. Upper endoscopy for vague, non-specific digestive symptoms, before trying simpler, safer approaches first. Number 3. Capsule endoscopy without a clear specific clinical indication and without evaluating intestinal motility to prevent capsule retention. Number 4. CT colonography in seniors over 75, given the risks of bowel preparation, radiation exposure, and the incidentaloma problem. Number 5. Repeated endoscopic surveillance for Barrett's esophagus in elderly patients with limited life expectancy and multiple health conditions, where the cumulative cancer risk may not justify repeated sedation and procedure risks. In every one of these situations, the right approach is an honest, individualized conversation with your doctor, where your age, your overall health, your other conditions, and your personal values and goals are all part of the decision-making process, not just a standard protocol designed for the general population. To every person watching this who is navigating the healthcare system after 60, you are not being difficult when you ask questions. You are not being uncooperative when you want to understand the risks before agreeing to a procedure. You are being exactly what every patient should be: informed, engaged, and respectful of your own body and your own values. Medicine at its best is a partnership between a patient who brings their full health history, their goals, and their honest concerns, and a physician who brings expertise, honesty, and genuine respect for the person in front of them. You deserve that partnership, and you deserve digestive health care that truly serves your best interests, not just at 45, but at 65, 75, and 85. If this video helped you think differently about how you approach medical testing after 60, please give it a thumbs up. It helps our channel reach more seniors who need this information. Subscribe to our channel and hit the notification bell so you never miss our weekly senior health content. Share this video with someone you love, a parent, a spouse, a sibling, a friend who is over 60. This kind of information can genuinely change lives. And drop a comment below. Tell me, have you ever felt pressured to undergo an intestinal test you were not sure you needed? What questions did you ask? What do you wish you had known? Your story might be exactly what someone else in our community needs to hear today. Thank you so much for watching. Stay informed, stay empowered, and I will see you in the next video.